Good evening, everyone, and welcome to the program Your Health 360. The times we're living in Nigeria right now, or should I say the whole world as a whole, I don't know how many of us have taken note of the fact that there has been a subtle shift or a continuous one, it's still ongoing, where people are beginning to talk more and more about mental health. In Nigeria, or should I say in Africa as a whole, I mean, even all over the country, it's not easy talking about mental health issues because it seems that over time we have allowed for it to denote weakness, some flaw in us, a deep flaw, flaw that many people cannot forgive. Meanwhile, we struggle with quite a lot. Well, today with me in the studio is Dr. Bashir Ada Abubakar. Dr. Bashir Ada Abubakar is going to be talking to us about bipolar affective disorder. And this edition, we've coined it as a hidden menace within our population. Dr. Abubakar works at the Neuropsychiatric Hospital right here in Barnawa. Dr. Bashir, it's good to have you with us today in the studio. Welcome.
Thank you very much. It's good to have you too. It's good to see you.
It's always good to have doctors here because we love to hear from you. It's our own way of doing regular checkup without really paying for it. You're welcome, Dr. Bashir.
Thank you.
Just so that the rest of us know, we're live on Facebook, so you can actually go and start to drop your questions right now so that I can take your questions as I see them. You can also inbox me either WhatsApp or text message to the number 090-7270-3270. Okay. Now let's start with you defining for us, Dr. Bashir, what exactly is this bipolar affective disorder? What is it? Because already we know it's bad because it's BAD.
It's really
okay,
bad,
so
yeah.
bad. But that's just on the lighter note. What exactly is this bipolar affective disorder?
Bipolar affective disorder. It's a common. It's a mental illness that's common, persistent, and it's a condition that's a life that the individual have this lifelong struggle and challenge. It itself, it's as I said, is a mental disorder of two poles. A pole in which this individual have this manic episode, we call it, and the other side, which is a depressive episode. The manic episode now is now characterized with increased energy, grandiosity. That's this individual feeling that it's a big person, an influential person. Also have symptoms like decreased need for sleep. That's having it difficult sleeping. He sleeps for a while, he gets satisfied, and use the remaining night rearranging and arranging things. He talks excessively, pressured speech, increased activity in everything. There's a lot of energy in this individual, activities even at work, at home, even and sexually. And this symptoms tend to affect this individual, affects his cognition, his behavior, his judgment, and his thinking. That's the pole of the manic, the pole called the manic. While depressive pole, which has to do with low mood. This individual has low mood, persistent sad feelings, decreased energy. He's unable to do anything at home. He feels reluctant to do everything. He's very tired, doesn't want to do anything. His chores he can do or she can do. Again, there's loss of interest in pleasurable activities. Things he used to do that he enjoys, he finds it difficult. He doesn't enjoy it anymore. With time, this individual tends to have difficulty sleeping. On the other, he can sleep. He may sleep, but this sleep he feels unrefreshed. And waking up in the morning, at the same time, he finds it difficult to start and also maintain sleep during the night. He wakes up at intervals with, again, he finds it difficult. There's low appetite. He eats less. With time, he tends to have weight loss. Continuously, it gets to a point that's depressive, but it gets to a point that he feels he's useless to himself and to the society. He feels he's hopeless. Sometimes he feels helpless, worthless, to the extent that he starts thinking of, since this world is useless, he's useless to the world, why not just kill himself? And he starts having thoughts, suicidal thoughts. So those are the two. However, it happens, it's not that everything happens at the same time, it happens, it's alternate. The manic side, that's the increased energy, the activities will start depending on which pole start. It might be depression, it might be mania. So it starts after a complete course. It's finished, then there will be some space where an individual might be stable, then the other pole tends to appear.
Now, if I get you right, bipolar affective disorder is actually something that has a range from one end to the other end. Is either there's hyperactivity or no activity at all. Now, trying to, because most of the things that you just described, doctor, to be honest to you, is something that I don't know if there's anybody that isn't experiencing one or two of those symptoms. Because
I understand,
as I sit before you, I would tell you that I really find it difficult going to sleep sometimes. And, on some days, I just don't want to get up or even go out. I don't want to have my bath. I just want to lie down and just like for time to just stand still. And then, when I manage to get out of bed, manage to have my bath, manage to go out, I meet people. And then, it's like everything is all right with the world. I'm laughing, smiling, and whatever not, with friends and colleagues in the office and the rest of it. So for me, while you were, talking about those signs and symptoms that you might be, I was just trying to use myself as a gauge. And there are several things that you've said that I've experienced. So how do we know that what you're feeling is not to be discountenanced, is not something that you disregard, that this has become a pattern and you need to go and see a doctor? How do you know the difference? That's what I'm asking.
Okay.
How do you know the difference between everyday feelings of feeling low, feeling tired, and then when you know that for this I need to go see a doctor?
Okay, thank you. As I defined it initially, as I spoke about initially, it's a persistent condition. Everybody tends to have times that he's happy, he's sad, but it's not persistent. He have it for a while and disappear. He goes out, continues normal activity. But individuals with this, apart from the fact that they have this symptom, it also affects their life, their lifestyle. It affects their cognition, their thinking process. They have poor judgment. In fact, their behaviors. Because with this persistence, initially, however, people say it. People complain with have these complaints of maybe sometimes there's increased activity. Well, if this increased activity is not affecting you, it's not affecting your life is not having any problem with your life activities, maybe your social activities, your occupational activities, then it's fine. It's just no. But the bipolar affective disorder affects the individual's behavior, the thinking, the cognition, the judgment. At the same time, affect his whole interpersonal relationship with people around him, with the society. Yeah.
So you're talking about, I just, so that we're very clear, you're talking about experiencing these ups and downs on a more consistent level. It's always happening. It's not like, okay, this week you just you had one downtime, next week you haven't.
No.
It's something that you experience almost every day, persistently. Talking about suicidal thoughts, it is sad to say, but suicide and the rate of it in Nigeria has become, I beg your pardon, even more common than any one of us wants to accept. Whether amongst the young or amongst the
Old.
old. You know, you talked about suicidal thoughts and tendencies beginning to enter into the matter of someone who is suffering from bipolar affective disorder at some point. You mentioned that when they're depressed, they start to think about this, but can suicidal thoughts also come in when they're having a manic episode?
Yes, they can. Because this individual, I said, there's this increased activity, he's happy, he's elated mood, everything about him is happy. It gets to a point, however, this individual, where, okay, we talked about suicidal thoughts in the individual, like when they start realizing they are sick and they are mentally affected, the thought of being sick and being mentally affected also affect them. And again, just with the increased activities, they have a lot of activities they do. They get tired. As I said, it's a pool. It's like it's alternate. But basically, with patient with the manic side, when they start realizing this is really a problem and they have affected the individual, the people around them, they get sober and start thinking of, okay, I've done this, so what's the need of continuing this life? So they start having that suicide. However, I said it's suicidal thought which may progress to completing the suicide.
Mm-hmm.
Yeah.
Now, Doc, when people start to get those feelings of, is it everybody that experiences both spectrums as having bipolar affective disorder? Is it every one of those patients that must experience the highs and lows of that spectrum, or like in the case of autism, where people just stay on one part of the spectrum? What really happens?
Yeah, for it to be called bipolar, there have to be this alternating depression and manic side. Because if it's just depression, the individual is having, so it will be classified under depression. And if it's mania, he will be classified under manic. Because apart from the fact that there's bipolar depression, bipolar affective disorder, there are also diseases. There are also mental diseases called mania. At mania differently, and there's also depression differently. When two of them coexist in an individual, then we call it bipolar affective disorder.
You know, reading up on this, realizing that very famous faces and personalities like Mel Gibson, Demi Lovato, Mariah Carey are said to, be people who are actually living with bipolar affective disorder. It begins to give us another perspective to how this thing can look. It can be so normal. It can look so normal. There's a very interesting story, I think. I'm calling it interesting for want of another word, that happened early this year. For those who follow all sorts of news, this couple, an NFL player in the United States of America, and he had been dating this black lady. A white guy had been dating this black lady for a while, over close on 1 year or something. Played for the Seahawks, I think. Chad Wheeler, his name. And one day she comes home from work and he has shaved his head. And while they were talking, he just started beating her. And even went to have yogurt or something. And then when she started moving on the floor, he said, "Oh, you're still alive?" She was able, thankfully, to call for help, and this guy was arrested. But I want to bring it back home, and let's talk about the rise. And as a matter of fact, more of an epidemic, or I would like to call it, of violence, gender-based violence, especially in many homes where a slap and thorough beating is only one word away. People who find it so easy to go into manic sort of rage where you're able to hit people with anything. As a doctor, would you say that people like that should get themselves checked?
Immediately. They should get themselves checked immediately. However, as I said, this bipolar affective disorder is a common disease, the common mental illness in our society. However, because of the fear of stigma, because not everybody will want to just pop up today and I want to go to see I want to go to a psychiatric hospital, I want to see a psychiatric doctor, because they have everybody. Okay, most of our Nigerian people, most of the black, have that ideology that psychiatry is meant for mad or crazy people, which is not like that. However, countries like developed countries like America with the actors, these are countries where the stigma is not as much as we have down here. These are individuals that found out, okay, they have this mental illness, and were able to contact the doctor early, because the earlier, the better. You see a doctor with these symptoms, they started experiencing these symptoms a bit, and they presented to a medical personnel, which evaluated them, probably sent them to a psychiatry doctor. After seeing them, he spoke to them about the illness, made them understand what this illness is all about, and the consequences of probably placed them on medication, psycho-educated them, and tell them the consequences of not taking the medications, and they too understood, and they were willing to abide by the rules and regulation. Probably that's why they won't have problems as such. They abide, and again, they are celebrities, so they won't want to be seen acting weird outside. However, for the NFA football, probably he has been stable for quite some time on medication. Probably it's either he stopped taking his medication, or the medication was medication needed to be adjusted. He defaulted follow-up, or things like that, which might probably he snapped and he assaulted his girlfriend. As I said, this the bipolar affective disorder, this is the manic part of this. However, the depressive part is mostly not heard compared to the manic part, because the manic part has to do with the violence, beating, feeling. But just imagine if he comes and say he feels like he's the king, and you're trying to say he's not the king. He gets. How will he say I'm the king? I'm God, and you're trying to fight me and telling you that I'm not. So he might get violent.
Is it everyone who goes through that manic part of the spectrum that thinks and utters what they're thinking, or do some of them actually go through that and not really voice it? They're acting it, but they're not voicing it. Because I'm trying to help us see, to be able to identify when these things are happening. Is it all of them who say, look, come, I'm God, come and kneel before me? Or do some of them just go through those episodes without really voicing and telling you how they are feeling?
Actually, not all of them. It comes in different. It presents differently. Some might start acting. Apart from saying that I'm a big person, I'm an influential person, they act it. Not like saying it and they don't act it. They act it. However, not everybody comes with this. Others comes with every other kind of symptoms. Some will come with increased activity, unable to sleep at night. They're very generous. You could just smile at them and just say good thing about them, and they give out something to you. So that's how it comes. It's not necessary that it has to be having that grandiosity within the symptoms.
How early in a human being's life can one begin to suspect that this person or this child or this baby is suffering from bipolar affective disorder?
Bipolar, I said, it itself, actually there's no specific cause. Like, this is what is causing it, and this is it starts mostly occurs between the age of 15 to 19. That's where it commences. That's when it starts, from age of 15 to 19. Another peak again from 20 to 24. However, we do have this illness in childhood and teen, but it's so difficult to differentiate a child with bipolar affective disorder, because as a child is very energetic. He plays around. He does a lot of things. However, when his activities, when the mood swing persists in this individual, there's a time he plays excessively, and there's a time he keeps moody or doesn't want to enter. Those are pointers, which the parent of this individual can quickly bring this person to hospital so that he'll be evaluated.
Is it hereditary? Are we born with it, or does it develop later on in life? What does science say?
Science says about bipolar affective disorder. As I said initially, there is no specific cause. There's no pinpoint. It's okay, this is what is causing bipolar affective disorder. However, other part we call it risk factors. They are genetic predisposition. When an individual, a parent, a mother, a father has bipolar, there's high chance of their children, their offspring, to have bipolar. However, it doesn't mean they must have, but there's high chance of having bipolar. As I said, mental illness, there's no specific cause. So anybody can just come down with bipolar affective disorder. But people which their parent have illness of such, there's more likelihood of them coming down. There's a high risk of them coming down with illness of such. When it comes to twins, twin studies show that if a twin is having a bipolar, there's high tendency of his other twin coming down with bipolar. Apart from that, studies just show maybe some biochemical chemical substance within the brain that increases and decreases, that leads to individual presenting with these symptoms. However, other social factors, the stress, when this individual is exposed to stress, post-traumatic stress, maybe childhood assault.
Exactly, Doc. That's where I was going. Sorry to jump in on you like that. I was going to ask that because even we have someone here, Usaina, saying that is bipolar affective disorder not caused by environmental factors that are hidden, like people who are abused and people don't know about the abuse early on. Yes, I've heard this before, that usually people who have been through some traumatic experience, many of them hidden, experiences where people around you don't really know. It could be rape, it could be, some sort of very traumatic incidents, and then it's left untreated. You don't have anybody to talk to, and then in some cases, drugs. Do we have these things really coming into play in bipolar affective disorder?
Yes, these are stressors. Stressors could range from childhood assault, rape, molesting, bullying, from marital problems within the house, the husband bullying the wife or the wife bullying vice versa. Or it could be from job, maybe unemployment, poor job environment. It could be any stress. However, as I said, everybody has a way to cope with stress. Those that they are predisposed, this stress tends to break them down, and they tend to present with symptoms. However, these stressors are not the one that specifically cause it, but however, they are a risk factor that an individual may come up with bipolar affective disorder.
So you're saying that it is not really those environmental factors, let's call them environmental factors. It's not exactly those environmental factors that cause it, but something
like
makes make other people more predisposed to
coming down with the mental illness.
Okay. If you're just joining us this evening, we have with us in the studio Dr. Bashir Ada Abubakar, and we're talking about bipolar affective disorder. We do know that it is higher. We have quite a number of people suffering from bipolar affective disorder in Nigeria, but as usual, we don't have as much data. Doctor, do we have a rough figure of what the bipolar affective disorder looks like in Nigeria?
Yes. There's a study done about epidemiology and the burden of bipolar by, I can't remember his name, Oluwumi Esan et al. The study was in Africa, but however, the one conducted here in Nigeria showed a prevalence of 0.1 to 1.83% in Nigeria. However, they found out that misdiagnosis, as I said, it's not everybody that wants to come out and show and say I have a mental illness. Those ones that were missed and didn't come along they found out they were about 36%. That means they are
36% of our population.
Yeah, this was a study done in 2016.
That is alarming, to say the least. 36% of the population. Oh, wow. Okay, so we're talking about bipolar affective disorder this evening with Dr. Bashir Ada Abubakar. We'll be getting to hear from you pretty soon. Do stay with us, and let's go on this commercial break. When we get back, the lines will be open. You get to ask your questions directly. Do stay with us. Your Health 360, only on Invicta 98.9 FM with Jacqueline Adedija. All right, we're back. Thank you for staying with us through that commercial break. And it is time for us to get to talk to you, because at the end of the day, is also about what resources, what solutions do we have available. And that's why, for me, it's fantastic that we have Dr. Bashir, because who else would know better about what we can hope to gain by visiting the hospital and doing so quickly, especially if we find that we or someone that we love is being described this evening, having been talking about bipolar affective disorder. It is time for us to get to hear from you directly. I took the only one question that I have seen, so it's time for us to hear from you. Let's open up the phone lines and take your questions directly. And the lines are open. The numbers are 081 40,000 989. Once again, that's 081 40,000 989 and 070 87 800 989. Once again, that's 070 87 800 989. While we're waiting for calls, I'm not holding my breath, because, the truth is, Dr. Bashir, when it comes to issues like this, a lot of Nigerians are not quick to pick up the phone and for people to hear their voices that they are asking questions like this. But I also have a program where we talk about things that we've seen in marriages, and I cannot help but think that there are some couples or some spouses in situations like this that I've met that might just be suffering from this ailment. We have a call, or several calls actually, surprisingly. Let's go take your call. Hello, good evening. Hello? Can you hear me? Uh-oh. All right. Hello, good evening. We're connected. Good evening. Oh, unfortunately, that call got dropped. Hello, good evening.
Hello, good evening.
You're welcome, sir. Go ahead.
Yes, I'm fine. I'm calling from Monday.
Okay, go ahead, sir.
Yes, please, ma'am. Where can I go and do the test? If I want to do the test.
Okay, thank you for calling. He's raised a very important question. How do you test? And if there is a test, where can people go to access this test? Dr. Bashir.
Okay. As I said earlier, mental illness has no cause. It's an unknown cause. There's an unknown cause. There is no specific investigation, blood-wise. There's no specific investigation that will show, okay, this individual has bipolar affective disorder. The symptoms is only, the diagnosis is only made clinically from the symptoms. When the patient comes with these symptoms, he experiences these symptoms, he comes, we evaluate him. Then, from the criteria we have for the diagnosis of the illness. Then we tell him this is the illness he has, and we have to place him on medication, and we psychoeducate him about the illness and counsel him on the medication, adherence to medication.
These medications, do they have serious side effects? Why do people stop taking drugs like this? Why do people break protocol and not continue? What is it that doesn't make people? I mean, you know that you're ill, you know you're supposed to take these drugs, but you still break with that protocol. Why?
Among the reasons is individuals, the patient with the mental illness, not understanding, not knowing what the illness is all about. Some of them, as I said, the stigma has a large role to play. The fact that they are coming to a psychiatric hospital, some of them are being forced to come here, and despite several education, you educate them, they still have that belief. No, they don't have a mental illness. They go back to either the mosque or the church. They get some prayers, and I believe everything is healed. When they feel they are healed, so they stop taking medication.
We have a call, Doc. Let's hear. The people need to talk to you. Hello, good evening. We're connected. Good evening.
Good evening. How are you?
I'm doing well. Thank you for asking.
Thank you
Go
very
ahead.
much, Jacqueline. Good evening.
Good evening.
Doctor, good evening. My name is Musa Bala.
Good evening.
Haji Musa Bala, you're welcome.
Thank you very much. The presentation is well educative. My only question to doctor is that I usually hear psychiatric doctor say temporary madness or temporary mental disorder. Temporary. Please, I need explanation about this word. Thank you very much.
All right. Temporary madness. Is there something like that? You know, do people go local briefly and then just go back to being themselves? You know, we have this saying where we say there's always 5 minutes of madness in every day. But on a more serious note, do we have that? Can people just go mad and then come back to being themselves?
Not really mad. As I said, we don't call it mad. We call it mental illness, because the mad is too strong. Mad or crazy, it's too strong. So we call it mental illness. And moreover, psychiatric hospital is not a place only for people that have mental illness. There are people that come with sleep problems, with seizure disorders, just like convulsions, with headaches, and so on and so forth, and other childhood illnesses. We don't call it mad. It's not really mad. Those are the problem we have, and people get stigmatized and they find it difficult coming. Actually, there's nothing like temporary madness.
Okay, it's good to know. But Doc, if one wants to come and see a doctor and you know, at least talk and explain oneself to the doctor, how do you go about it? You know, because the neuropsychiatric hospital, like you know, is not exactly the type of hospital where you just walk in and just stroll around and say, okay, I need the reception from reception. I know it might be like that, but for a lot of us who, you know, still have that reservation about, you know, visiting a mental health hospital or something, walk us through what it can be like on any good day when you want to go there.
Okay. Actually, psychiatric hospital is the easiest hospital you could come to, and you get attended to easily. The problem with people is that they find it, the thought of coming to a mental hospital, psychiatry, and their thought is like they come and see mad people everywhere, which will harm them. So they find it difficult coming. But however, psychiatric hospital is the easiest place to come to. In fact, any patient anybody with a mental illness, when you come to hospital, you just go. We have sections. We have the emergency sections, the general outpatient section. In fact, when you come, we take our time. For the first patient, for the patient coming for the first time, we take longer time talking to him, explaining his illness. We give him time to talk, to say everything in his mind. We take like hours listening to him, just to get him satisfied and comfortable to say whatever he has. And after he finished saying his problem, we explain to him what his problem is, place him on medication, and we see them on regular basis. Maybe we see them after 2 weeks. Then subsequently, when the patient starts getting better, we give longer appointment.
If the patient starts to experience, because I've heard this, and I'm just going to, you know, go ahead and just ask you, depressed sexual appetite, I think, is one of the reasons also that I've heard why patients do not stick with their medication.
Yeah.
what should a patient do if they realize that they're having low libido, for instance?
All they do, actually, medications we give, the medications we give, they also have their own side effects. But however, when any patient is experiencing anything of such, all he needs to do is just to come to the hospital and report his problem, and we'll sort it out.
Just come and talk.
Just come and
Do
talk.
we have psychoanalysts? People, you want to talk to someone to have. Okay, let's go take calls, doc. It's important that people talk to you. Hello, good evening.
Hello?
Yes, you're welcome. Go ahead.
Mine is a question.
Go ahead,
Okay,
please.
go ahead, please.
Yeah. I don't know if mental illness transmitted. Because I used to hear they say that if a madman bites somebody that he can be infected. So is it transmitted?
Oh God! Which kind of bite? Why would a madman bite you? Anyway, I don't know, Doc. You should answer that while we're waiting for another call. You answer him.
Okay, actually, there's nothing like that. There's no way a madman he lives in his own world. Sorry, not the mentally ill individual. He lives in his own world. He won't bite you, and even though he bites you, probably you're the one that came and tried to attack him. Or however, some can attack you. However, biting won't he won't transmit the mental illness to you by biting you.
Okay, so mental illness cannot be transmitted via saliva
No.
or anything like that. Still taking your calls this evening. Bipolar affective disorder. Who do you know? Or are you even the one who might be wanting to examine yourself even more? Hello, good evening. We're connected. Good evening. Hello. Well, this person does not even know that we're connected yet. Hello. All right. So, Doc, let's talk about something else that you touched on, and I know that it's also something that people might not want to ask questions about. I'll save it for last. We have another call. Hello. Good evening.
Hello, good evening.
Yes, go ahead. You're welcome.
Yeah, thank you. My name is Yakubu.
Go ahead, sir.
Yes, and I have a question for the doctor. Do they have any body, a means of, relating these kind of problems and notifying our government in respect to the mental illness that he just spoke about? Because in no distance time, right now we're going to have a big challenge on the society because of this kidnapping, raping, what have you, suicidal thoughts from different places. Because people are actually losing their jobs, and do they have any means of relating it to the government so that they should know about this? Thank you.
All right. Another very, very interesting question. I think we have a situation where we have a lot of people who have been raped, and Doctor, funny enough, I've heard it's not just men, the ladies, even men being raped. We have the situation with the kidnapping and all of that. And so we have a neuropsychiatric hospital that, is federal, I should think.
Yes.
Is there any program that I know you might not be able to answer this, but it's worth looking at. Yes, that we should have avenues where people could actually come and talk because it's not easy telling anyone that you've been raped or that this is what my experience has been. Okay, still taking your calls. We still have time to take a few more calls before we call it wraps this evening. But before we go, like I said, I'll save my own question for last. Good evening.
Hello, evening, ma.
Yes, go ahead, please.
It's Shaman from Agwambulu.
You're welcome, sir.
Yes, ma. This bipolar affective syndrome. People that are hostile naturally, that becomes very hot with a simple approach. Does that has to do with bipolar affective syndrome? That's my question.
Okay. And thank you for your question too. People who have very, very short tempers, people who can flare into rages, like very high annoyance. at the simplest of things, could they be suffering from bipolar affective disorder? Because I think people are taking a look around them and beginning to wonder about this person or that person. Hold your answer. Let's take this call too. Hello, good evening.
Hello?
Yes, we're connected.
Good evening, ma.
You're welcome. Go ahead, sir.
Good evening, doctor.
Good evening.
This is Naftali. I'm calling from Sabu.
You're welcome.
Mine is a question I want to know. What is mental illness hereditary?
Okay. All right. Thank you for your question. Let's have Dr. Bashir answer. Dr. Bashir, you now have several questions. You have the person who is asking whether mental illness is hereditary. There's the person who asked you before now whether or not people who fly into very high temper, very short. It's little things get them very, very angry. Are they also people who can be said to be on the bipolar spectrum?
Okay, for people like that, that easily get irritable and angry, as I said initially, the diagnosis, that's the bipolar affective disorder, is a persistent condition. For individuals, they just easily get irritable along the way, but however, that irritability doesn't affect their livelihood. It doesn't affect their social interaction with individuals. It doesn't affect their occupational. It doesn't affect their work. It doesn't affect their judgment, their thinking, their behavior within the people. It's fine. That we call it personality. That's his own personality. People, there are several people. Some
but
are
people
calm.
who get angry, Doc, you think it wouldn't have affected their relationships? It wouldn't have affected their jobs?
No. Those that affect their social interaction with individual, with people around them, their occupation, their relationship with even their parents and family members and neighbors. People like that. I said, if it is persistent and it's sometimes he has those symptoms and later he gets depressed, he's low mood and nothing is interesting to him, he finds nothing more interesting, he's sad, that means it's a mood swinging kind of behavior. Sometimes he's irritable, easily angry, sometimes is sad and low mood, no energy, just not interested in anything. People like that, we start thinking of probably it's people that may have bipolar affective. But if it's just he being just irritable at every cause, anything that happens is irritable, we might want him to come to hospital for evaluation. He might be having the manic part, the manic episode, not bipolar. I said bipolar has to do with the two poles, depression and depression or mania.
All right, let's take another call. Hello, good evening.
Hello, good evening, ma'am.
You're welcome. Go ahead.
Thank you. Honestly, Mrs. Jacqueline, just want to appreciate you for these educative programs you are bringing to us. It's actually very rich, and we are happy to have it success.
Thank you.
Thank you so very much. The Lord bless you. We are happy.
And thank you too. Thank you.
Yeah.
All right. So have a great day. Thank you for calling in. Your words mean a lot. Dr. Abubakar, you've heard from the people. If we get another call before we go, we'll take it. But the question I was going to ask is about, this either very high libido or very low libido. Could it also be a classic sign? Hello, good evening. We have another call. Please move away from your radio set.
Hello?
Yes. Good evening.
Yeah, good evening. This is Mr. Blessing.
Go ahead, sir.
I want to ask this question.
Yes.
What is the Ministry of Health doing concerning those people that are mentally affected? In the society, we see a lot of people on the road. We pity them. We cannot help. Is there anything the government or this health ministry can do to it?
Okay. All right. Well, thank you for your call too. Let's take another call. Hello, good evening.
Good evening.
You're welcome. Go ahead, please.
My own question is that I'm having a baby.
Please, could you speak up?
I think I'm having a baby. It's up to 3 years now. more than 3 years, but he's not talking. I don't know whether that one is
Okay, a baby that is about 3 now, and he's not talking.
yes. But if you talk, he responds to what you said.
What you've said.
They don't talk on the phone.
Okay. So you're asking, are you asking if there are resources for that kind of situation, that kind of condition at the
Yes.
neuropsychiatric hospital? Okay.
Yes, ma'am.
All right. Thank you very much for your call. Dr. Abubakar, you've heard the people.
Yeah.
The lady who is asking about her child, 3 years old, not speaking yet. Do we have resources? And then the person who is asking what the government is doing, the Federal Ministry of Health, actually. I do know, I don't want us to put you on a spot, so you don't have to answer anything that you don't want to answer. Yes, all right. So, do we have resources?
Yes. For children that don't talk, probably before they are meant to talk at the age they are meant, but they are not talking, we would like to see them. We see them, then we evaluate what is really a problem. With children, they tend to have, if not bipolar, other mental illness. Maybe when they were given birth, there were some complications around that birth period. He might have jaundice, he might have seizure, convulsions, febrile illness along that period. So finding it difficult along as he's growing, he tends to, there's delay in developmental minds too. Probably he's not sitting when he's meant to sit, he's not walking when he's meant to walk, he's not talking when he's meant to talk. So patients like that, we see them, then because we have a section in the psychiatry, there's a child and adolescent section, which we take care of conditions like this.
Okay. All right. So that's good to know.
With respect to the genetics, if it's hereditary. Actually, as I said initially, when the parent of this, even the parent of individual, when the parent have a bipolar affective disorder, there's chance of a child or their children having. But however, that doesn't say they must have. It's just a risk factor that there's high tendency of this child may have. But however, he may not have. It's just a risk factor. It's not that he has to have by force.
Okay. It's now that we're about to wrap up that we're having so many calls. Let's see how many we can take. Hello, good evening. You have 30 seconds, please. We're connected. Hello? Okay, we cannot hear you. Please try again. Let's see if we can hear from you before we go. For instance, Doc, a man or woman who find that their partner has suddenly has developed a very high libido every night. I mean, they want to go, it's beyond what it used to be. Or those who just suddenly realize that it's not even existent anymore. Are these classic signs of bipolar? And if not, if so, what do they do? If not, do we have resources for people like that too at the neuropsychiatric?
Yes. For individuals like this, there's time they have increased libido, there's time they don't have low libido. However, with that's also part of the symptoms. But however, with other symptoms, maybe the increased activity, increased energy, and grandiosity, all those, in addition to the increased libido, and there'll be a time that there'll be decreased no libido, low appetite, loss of interest, low mood, decreased energy. That tilt, that mood swinging, situation. Yes, please, individual like that can come to hospital because that also it's a pointer. They come, we evaluate if it's the condition, we place them on medication, counsel them, advise them on adherence, and explain to them the condition they're having.
You know what, Dr. Abubakar, I think I would like to pay a visit. I'm going to use you to pay a visit and just come and talk. Just come and talk so that we can demystify.
That would be nice.
Demystify this thing about people seeking help for their mental health. It's very important, especially seeing as a lot of us are going through many things as we go along in life. The world isn't easy, and we are not made of stone. So I'll pay a visit, and I'll put it up on our YouTube page for people to see how easy or how difficult it is to go to the neuropsychiatric hospital. But in closing, Dr. Abubakar, your words of advice for us as it regards mental health, especially on bipolar affective disorder before we go?
Okay. So mental health, as I said initially, it's is an illness of the brain, and anybody can have it. It does not specify that this set of people are meant to have it, or is a male that's meant to have it. No, just like other illnesses, having the liver disease, the kidney disease, the mental illness is the worst illness you can have, because you have a mental illness. It means you're not in touch with reality. So the earlier the better. When you start seeing symptoms of abnormal behavior, abnormal thinking, poor judgment, physical assault, verbal and physical aggressions, these are pointers.
Can people report, or do you have to get a report from the police, for instance? For instance, a woman whose husband is especially abusive, like what I've described, that I've heard, coming out of homes. What do women or men like that need to do? Because some of these people might actually need the help we're talking about, but are unable to realize that they need it and access that help. So what can they do quickly before? Just 30 seconds talk.
Okay. Going to the police, that's if the person is violent, fine, you can get the police to bring him to hospital. If he can easily come accompany to hospital, you can bring him to hospital. Because some of my patients, the patient relative tends to bribe them, say some words that they come to just escort me to hospital for some, so that they'll be like they are the one coming to hospital, but it's the patient they are bringing. So there are many ways you can bring this patient to hospital, either by getting security people around to bring him, or by convincing him to bring him.
Well, we'd like to thank you very much, Dr. Bashir Ada Abubakar, for coming in to speak with us this evening. I do hope that all our listeners will try their best. Like I said, I will, during the week, go out and find out how easy it is to find someone.
We'll be expecting you.
To talk to. I will, and I will make a video of it and put it up on our YouTube page. But it is, suffice it to say that none of us is superhuman. None of us is Thor or Batman, and even those superheroes, at some point or the other, they need help. If you find that you're struggling, let's find help before it gets too late. And the chaps on For the Place, they're already signaling time for them to come and talk to you this evening. I do hope you had a great time with us. I'm signing out. Dr. Bashir, once again, thank you.
Thank you very much.
Until next Friday, when we come your way again with Your Health 360, remember that there is no shame at all in seeking help for your mental health. Stay victorious.